Good morning, one and all. We welcome you all to the 15th webinar of IAPWC Goa. This time we have chosen the topic of behavioral issues in children with special needs. We will be doing a series of these webinars, and first in series we have very good morning, Dr. Aparna. Today we have with us Dr. Aparna, who is a pediatrician. She is a developmental and behavioral pediatrician. So today we'll be starting with her, and today's moderator is Dr. Gauri. So without much delay, I would request Dr. Gauri, please take the session forward, hoping for it to be a very interactive and interesting session. Thank you.
A very good Sunday morning to everyone. Myself, Dr. Gauri Kamatwag, welcome you to this 15th webinar organized by IIP Women's Cell Goa on the topic Behavioral Issues in Children with Special Needs, Part 1. We are all aware that parenting of a child is not easy. And when it comes to parenting a child with special needs, it's even more challenging. It definitely requires extra effort in time, patience, and persistence, awareness of the child's needs, and many more accompanied challenges that come along the journey of upbringing the child with special needs. Many of these children may not be able to communicate their needs or trouble that they experience, which may in turn come out as a disorganized behavior and perceived by others as behavioral tantrums. It may so happen that only because of these behavioral issues, the child may not be socially accepted. Hence, it is very important that we as parents, caregivers, or professionals handling these children recognize the issues at the earliest and intervene early, focusing on appropriate measures to bring those behavioral issues under control. So IIP Women's Cell Goa has brought to you a webinar series to address this topic, right from diagnosing these issues to treatment and remediation by various professionals who are working in this field. So without wasting much of a time, I introduce to you our speaker of the webinar series part 1, Dr. Aparna Wadkar. Dr. Aparna is a developmental behavioral pediatrician. She is working as an assistant lecturer in Department of Pediatrics in GMC since 2009 and administrative in charge of Pediatric Neuro Rehabilitation Center in Goa Medical College at Bambolim since 2010. She is also state level coordinator for Indian Academy of Pediatrics chapter of Developmental and Behavioral Pediatrics. She has presented several papers and posters at national and international conferences. Her recent paper was on sleep problems in autism spectrum disorders, a study of prevalence and behavioral intervention at International Developmental Pediatric Association Congress at Philippines. She's a master trainer for ILLNE tool and also the national modules of various neurodevelopmental disorders under the Indian Academy of Pediatrics and have conducted several training programs and workshops for clinical and paraclinical doctors and parents in Goa. I welcome you, Dr. Aparna Wadkar, on behalf of IIP Women's Cell Goa and request you to share your knowledge and expertise with us. Dr. Aparna, you can take the charge of the platform now.
And Dr. Gauri, I think she has logged out. She's just joined in. Thank you for waiting, attendees.
I think there are some technical issues. Kindly hold on. She will join us soon.
Gauri, can you hear me?
Doctor, you're audible. You can start, Dr. Aparna. You're audible.
Dr. Aparna has joined us. Dr. Aparna, kindly screen share and you can take the platform.
Hello, Gauri.
Yes, you are visible and audible, Dr. Aparna. Kindly screen
Slide
share.
share. Some
Yes,
technical
kindly
issues.
screen share and we can start.
Can you see the screen now?
Yes, we can see
See the
it.
screen?
Yes, we are able to see the screen and we can hear you as well as we can see you. So we can start now.
First of all, a very good morning to all the panelists. I thank Indian Academy of Pediatrics, the Women's Cell, for inviting me for this webinar, for choosing a wonderful topic, the behavioral issues in children with special needs. I hope this session will be a very interactive one. So coming to behavior, first of all, we should know what is behavior. Behavior is learned action. It serves a function. It communicates needs. And we have to most importantly know that it is measurable and observable. We all know behaviors that are exhibited by a child, they serve some function. Okay?
Dr. Aparna, sorry to interrupt you. The voice is actually breaking. Could you please just see if you can come in range?
You can hear me?
Closer to the mic, we can hear you, but the voice was breaking. So kindly come closer to the mic.
Okay. Can you hear now? Coming
Yes.
to the functions of a behavior. First of all, whenever we see a child with behavioral problems, we have to ensure what is the behavior trying to tell us. Whether it is trying to gain attention, which can be a positive attention or negative attention. Positive attention as in praise or negative attention as in yelling. Whether the child's behavior is communicate or to try to obtain a desired outcome, maybe an object or something like that. Or if the child is trying to avoid an undesirable task, suppose if you are trying to make the child write and the child is throwing a tantrum that time, the tantrum could be because the child is trying to escape the writing task. Or sometimes the behavior could be to self-calm, to self-regulate or feel good, as in stimming behaviors which are seen in autistic children. Or sometimes it could be just a sensory avoidance behavior, as in the child closing his ears. There are loud sounds or the mixer going on. This is a sensory avoidance behavior. Or sometimes the child's behavior could be trying to gain control over its environment. Now, why so much ruckus about focusing on behaviors? Like we as therapists and we as pediatricians deal with parents daily. And most of the times, the parents come to us with challenging behaviors. What we should know and what we should mainly understand is that challenging behaviors are very common. And if behavioral treatments are effective for improving the skills and to reduce the challenging behaviors, we can do that with good behavioral treatment strategies. One should always remember that earlier the interventions are started, better are the outcomes. Now, changing difficult behaviors. When does a behavior become a problem? When it interferes in the learning process of child, when it causes injury or harm or to self or to others, when it prevents the child from performing usual life routine activities or any activities that a child is able to participate in, when the behavior results in adversely affecting the mental peace, health and general functioning of the family members and others in the environment. Now, whenever we see a child with behavior, what are the things that we should note? First of all, we should see whether the behavior is normal for the age or abnormal. Like suppose if we see a child who is mouthing and the baby is around 8 months old, definitely that behavior is normal. Whereas if I see a child who's still mouthing when the child should be having constructive and symbolic play at 4 years of age, definitely that behavior is not something that is, normal. So that behavior is abnormal for the age. Then we should see that the behavior is age developmentally appropriate. Suppose if we have a child who's 6 years of age, but very restless and hyperactive, then that behavior is not something that is going to go with the behavior, because it's going to interfere with the learning in the school settings. Whereas if we see a child with 2 years of age who's having these problems, then again, the behavior is definitely going to be abnormal at 2 years of age, at 4 years of age. Now, what are the components and measures of the behavior, and what are the behaviors we need to prioritize? There are a lot of things that we need to teach. Okay, all parents will tell us
Dr. Aparna, your voice is not audible.
Am I okay? Were you all not able to hear anything?
Now it is all right. Now you can go on.
From which side do I start, Gauri?
I think the second one. After the definition.
Oh.
And doctor, could you please be closer to the mic so that we will be able to hear you better?
Okay. When I was see a child with behavior, first of all, we have to see whether the behavior is normal or abnormal. Is the behavior age and developmentally appropriate? What are the components and measures of the behavior, and which are the behaviors we need to prioritize? Now, if suppose we see a child who's of 2 years of age and he's having mouthing problems, then that is definitely something that we would not like to see in a 2-year-old patient. Whereas the same behavior is seen in a baby who's 6 to 7 months old, then definitely that is normal. Because if we go by the few stages of development, in the first year of life, it's the oral stage where the children learn by sensory motor exploration. That is everything that goes to their mouth, and they learn that what are the things that they are putting in their mouth. Then we have to see whether the behavior is age and developmentally appropriate. What are the components and the measures of the behavior, and which are the behaviors that we need to prioritize? Am I audible right now?
Yes, doctor, you're audible. You can just inform Dr. Smaranika to change the slide. So you can just say next so that she can change the slide then, because she is sharing the screen. Okay? Yeah.
Okay. Now we should know like which are the methods that we are going to choose. Like, see, whenever we see a child, even in outpatient department, many parents will tell us, I want this behavior to change, I want that behavior to change, or this behavior is overwhelming for me. Okay, but the thing is, as a developmental pediatrician and even a therapist, we should try and see which is the best behavior the parents find overwhelming, and which is the behavior that we need to change. So we cannot deal with all behavioral problems at one time. We will have to choose one behavior that is causing severe functional impairment in the child and causing a lot of mental agony, not only to the parents, as well as to the surrounding caretakers. Next. Next. Okay. Coming to the common behavioral problems. Now we see a lot of behavioral problems. Okay. The main behavioral problems include like mouthing, temperament, irregular feeding habits, sleep behavior, inappropriate toilet habits, self-stimulation behavior, repetitive behaviors, hyperactive or impulsive behavior, aggressive behavior, and oppositional behavior. I have already spoken about mouthing. Now, what is temperament? Temperament is the individual style of reacting with or responding to the environment. child's temperament is something that a child is born with. We cannot change it. But definitely we can change the surroundings or the environment. So we see children who are like very easygoing. We see children who are like, who have a very difficult temperament. Or we see children who are cautious, or like we would say, they are slow to warm up. Easygoing children are the ones who adapt to new situations, are always in a good mood. They have good energy levels, but not high also. And their approach to new situations is very good. Difficult children will be the ones who will have difficulty in adapting to new situations. They'll be like forever in a bad mood. They'll be like hyper most of the times. And even like whenever they are going to a new situation, probably they would take
Dr. Aparna, you aren't audible. Again, the voice is breaking.
Just a minute, Gauri. Is it better now?
Yes, it is. You can continue.
Were you able to hear anything on temperament?
Yes,
Dr. Gauri?
yes. You can start from temperament. Dr. Aparna, you can start.
When we say the temperament is the innate ability of the individual to respond to one's own environment. There will be children who will be like easy, cautious, or difficult. There will be children who have a very difficult environment, temperament, and their mood will be always poor. The activity levels will be very high, and sometimes they may approach or withdraw in a new situation. Now, next slide. Coming to irregular feeding behaviors, they manifest as poor appetite, poor weight gain, picky eating, inappropriate mealtime behavior, and excessive appetite sometimes. Gauri, I'm not able to understand whether you all are hearing me or no.
Now it's very clear, doctor. You can continue.
Okay. Thank you very much. So, the irregular feeding behavior manifests as poor appetite, poor weight gain, picky eating, inappropriate mealtime behavior, and excessive appetite. Now, picky eating is something that we usually see in the children between 19 to 24 months of age group. Autistic behaviors usually exhibit as, narrow range of feeding patterns. They include unusual consistencies of food, and they have inappropriate mealtime behavior. Sometimes some children with some syndromes, such as in Prader-Willi syndrome, exhibit lot of appetite, as in sometimes the parents even have to close and lock the refrigerators in order to inhibit the children from eating the food. Tantrums. Tantrums are behaviors that are seen in children from 1 year to 4 years of age group. And every child passes through tantrum behaviors. It is basically due to emerging desire to become independent, both physically and emotionally. But tantrums are more seen because of limited motor and cognitive skills like planning, organization, execution. Thus, there is frustration and persistence of tantrums. Other behavioral patterns that we need to see are repetitive behavioral patterns. These are rhythmical patterns of behavior that occur repeatedly. They may serve to comfort the child. They increase in situations of anxiety and boredom. And these include like thumb sucking, rocking, pica, mouthing, hand flapping, and spinning. Thumb sucking is normal till 4 years of age group. However, if the person is exhibiting dental problems, as in anterior open bite, or if there is damage to the tissue, like if suppose the thumb is developing paronychia or the other digits are developing paronychia, then definitely this is one behavior where intervention will be required. Rocking is also a kind of a self-calming behavior which are seen in children less than 1 year of age group. But if rocking persists in children beyond like 2 to 4 years of age group, then we have to ascertain the cognitive level of the child and follow the child up to see if there is intellectual disability. Pica. Pica is actually eating unedible substances. So there will be children who will be eating mud, paints, or they will be eating ice, they will be eating agarbatti powder. But pica is normal till 1 year, wherein the children don't know what are the things that they're supposed to put in the mouth. But sometimes pica could be because of iron deficiency anemia. So whenever we see a child with a pica behavior, then we have to ascertain whether the child's iron status is normal or no. Then coming to hand flapping and spinning. These are the behaviors which are exhibited in children with disorders. This I'm sure will be dealt in future by other therapists who will be taking the lecture for you. So these are some of the behaviors that we see: rocking, obsessively switching light on and off, eating unusual objects like clothes, mattresses, or drapes, and finger flickering in front of the eyes, which are mostly in children with autistic spectrum disorder and also in children with intellectual disability. This mainly happens sometimes because of sensory overload also, when the children exhibit these behaviors because they want to calm themselves. Now, coming to the most important part of it, that is the challenging behaviors. How do we define challenging behaviors? They are culturally abnormal behaviors of such an intensity, frequency, or duration that the physical safety of the person or others is likely to be placed in serious jeopardy, or behavior which is likely to seriously limit or deny access and use of ordinary community facilities. So any behavior that inhibits the child's participation in the society, that inhibits the child's learning process, or inhibits the child's participation in day-to-day activities with his peers, with his family members, is something that we have to take on as challenging, and we have to do interventions. So some of the most common challenging behaviors that we see in children are agitation, aggression, self-injury, sleep disorders, and inappropriate sexual behaviors. Am I audible, Dr. Gauri? Hello?
Yes, doctor, you are audible.
Hello?
Doctor, you're audible. Please continue.
Dr. Aparna, you can continue.
Behaviors cause interference in group learning. They cause interference in group learning. They cause social isolation of the individual. They decrease the community participation of individual. It causes unnecessary anxiety in the parents. It is also a financial burden. See the screen?
Dr. Aparna, we could not hear
Hello?
you. Please repeat from the last, after financial burden.
Okay. Can you hear now? Doctors?
Yes, doctor, you're audible.
Okay. So when I will move from financial burden, definitely causes lot of problems to the parents, because they have to hire a caretaker, or sometimes the parents have to leave their jobs and look after their children. And there is overall poorer quality of life to the child as well as the caregivers. More so why? Because the children, because of the challenging behaviors, are not taken out. They are kept in the house. They do not participate in, peer activities. They do not participate in competitions. Or sometimes because of them, the caregivers also can't go for any functions. So these are the reasons why challenging behaviors have to be addressed. Okay, then what do? We have to obtain a detailed medical history whenever we see a child with challenging behavior. We have to see the onset of behaviors, whether the behaviors are acute in onset or they have been present. Then we have to see how the behaviors have evolved. Have the behaviors just started abruptly, or were they present over a period of time? What are the aggravating factors and situations? Whether there are some situations, as in during the school hours, the behaviors are more, or in the presence of certain caretakers, the behaviors are more. Those are the things also we have to ascertain from in the history. What are the functional impairments? Is the child able to participate in peer activities? Is the child able to participate in school? Is the child able to participate in community activities? So all these functional impairments we have to look into. Most importantly, we have to rule out psychiatric illness. Most of the children with developmental problems have sometimes caretakers, or they have some family history of psychiatric illness in their family. So a detailed family history has to be taken, and we have to look into the impact of the behavior on the other family members. Next. So when do we suspect psychiatric illness? If suppose we see a child who's come with acute behavioral symptoms, like the child was having normal behavior, suddenly there are some behaviors that come with, then that is the time we have to suspect psychiatric illness. So if suppose if we have a child who's on the autism spectrum, and at 8 years of age group, he starts having repeated hand washing behaviors, then we have to suspect obsessive compulsive disorder in this child. Or sometimes there can be a history wherein the child had fever during that time, or some lesions on the body. So we have to suspect PANDAS. So it's pediatric autoimmune neuropsychiatric illness. Or there can be sometimes exacerbation of the baseline behavioral symptoms, as in the child who was like having normal behavior, as in good behavior, the child suddenly goes very much depressed, as in what we call as psychomotor apathy. Or sometimes the child can have severe behavioral outburst, which is called as agitation. So that time also we have to suspect psychiatric illness. Or if suppose the child was following a good behavioral approach and responding well to the behavioral interventions, and suddenly the behavioral intervention strategies have just gone for a toss, that time we have to suspect psychiatric illness. Next. Next. Dr. Smaranika. Okay. As a pediatrician or as a therapist also, we have to rule out some organic causes of behavior. Now, if we see a child who's having persistently early morning tantrums or persistently early morning behavioral issues, then what do we see? We have to rule out whether the child has been sleeping well the previous night. And in most of the children between 6 to 10 years of age group, there can be symptoms of obstructive apnea because of hypertrophic tonsils or adenoids. So we have to rule out tonsillar hypertrophy or adenoidal hypertrophy in these patients. Sometimes because of communication difficulties, as we know, because some of the children with severe intellectual impairment may not be able to communicate that they are in chronic pain. And most of our children have dental caries. So we have to rule out whether the child is having any tooth pain. Because of the GI problems in them, they will be also having persistent constipation issues, because of which the child's aggressive behavior can worsen. So a detailed history into their bowel bladder habits and also a detailed history of their dental and other pains should be taken. Also, we see a lot of children who exhibit a lot of behavioral difficulties because they are being sexually abused. We recently had a case where there was abuse in a child, but sexual abuse is actually seen in 60 to 80% children of developmental issues, but they are underreported. I'll come to it in detail later. We have to also ascertain the use of medications. Most of our children are on chronic medications, maybe because of epilepsy, maybe because of sleep problems, or maybe because of other comorbid conditions. So we have to ascertain whether the child is having any change in the medications, or maybe the medications were just started and because of which there is a change in the behavior. Like there are some drugs like benzodiazepines, like diazepam, clonazepam can cause some behavioral changes in the children. Also, levetiracetam is most commonly used drug in the treatment of epilepsy. This drug also causes severe behavioral changes. If suppose the behavioral changes are so challenging that it impedes and inhibits the child's participation in the environment or into the society, then definitely we'll have to bring it to the attention of the treating doctor. And another thing is GERD, that is gastroesophageal reflux disease. GERD is most commonly seen in children with cerebral palsy, in children who are chronically bedridden, or other children with, who are with GMFCS 3 to 5 stage. Next slide. So what is the next step? The next step is to see the behavior and to see what are the controlling variables which are controlling the behavior. So we have to gather as much as information as possible. Maybe from the parents, maybe from the caretakers, maybe from the nurse who is like hired for the child, or maybe from the physiotherapist, the speech therapist, the settings in which the behavior occurs. We have to take interviews, we have to sometimes give self-reporting scales, and we have to do a functional assessment. Next. So what do we do in a functional assessment? I'm sure most of you all know it, but I just want to reiterate what is the importance of a detailed functional assessment. When we say a functional assessment, involves three things: antecedent, behavior, and consequence. Behavior is what exactly the child is doing. Maybe he's spitting, maybe he's hitting, maybe he's biting.
Dr. Aparna, you're not audible.
There is always
Dr. Aparna, we cannot hear you. Can you please come back again? Attendees, kindly bear with us. Dr. Aparna has lost her connection. She is rejoining back. In the meantime, we would be sharing a feedback form. Kindly fill that so that we can send you the presentation. Yes, yes. Dr. Aparna is joining us back in just 30 seconds. Kindly cooperate. In the meantime, if you have any questions till now, you can please put it on the chat box. We are also live on YouTube, so you can put it either there or here.
Can you hear me, doctor?
Yes, you're audible and visible, doctor. We can start back.
So we have to see the components of the behavior, categorize the behavior, whether it's normal or abnormal, as I told you already. Then see the setting event and do the ABC, that is the antecedent, functional behavior, and the consequence. Next. So categories of behavior. So we have to see whether it is a developmental variation, we have to see whether it is a problem behavior, or we have to see whether it is a disorder. Developmental variations as in mouthing, which the child outgrows. A problem would be a mild problem which does not fulfill the DSM-5 criteria. Or disorders as in ADHD, or maybe autistic spectrum disorders, or obsessive compulsive disorders, which fulfill the DSM-5 criteria. So very important is that we see the behavior and categorize it according to the about three categories. Next. So we have to see also the setting events in which the behavior occurs. If there is pain, constipation, seizures, and drug treatment. Next. So as I said, this is just a repeat of the behaviors. Next. This is just one example of how a ABC chart looks like. So here the behavior is head banging. The antecedent is that Ravi was going to school. He sees the school bus. What is the consequence? The parents would not send him to school because the child is exhibiting head banging behavior. Now, what is the function of this behavior? The child was displaying head banging in order to avoid going to the school. And every time the parents would take him to the school bus, he used to bang the head. And parents, because he's head banging, would take him back to the house. So his behavior was getting reinforced. It was not only worsening the anxiety of the parents, but it was also causing loss of school hours. Next. So at the end of it, we should be able to identify whether the behavior is a problem, whether it is just a normal variation or whether it is a development. If it is a problem behavior, then we can do the ABC analysis, start the intervention. It is a developmental behavior. I think we have to hold some restraint and wait for the problem behavior, wait for the development to take over. Also, we have to see the extent of the behavior, the situations wherein the behavior occurs, and make a difference by ruling out the organic cause. The goals of the treatment at the end of it should be to reduce appropriate behaviors. Next. And to promote positive behaviors. So if we want a child not to do a undesirable behavior, we have to ensure that we are giving the child a good, appropriate, positive behavior. Next. So this is just an example of what intervention was done in this patient. So he was head banging and the parents were not sending him to school. So after the intervention was given, what we did, we were not giving the child attention with eyes. So not give eye contact to the person. Do not yell, because that is also a sort of an attention. Eye contact is a form of attention. Mouth, that is yelling, is also a negative attention. But you have to ensure that the child does not have damage to his head. So ensure that you look away, you put your hand there and you protect the child's head. But as soon as the child stops yelling, praise him, give him descriptive praise. Oh my God, you have stopped yelling now? Okay. Or maybe give him an instant tangible item. Maybe if he likes natural tangibles, like if he likes a chocolate, you can give him the chocolate. Or if he likes stars, you can give him star. So his good behavior is rewarded. Next. So strategies should be based on why the behavior, and we have to change and try to teach alternative behaviors to the child. Structure for the situation. Develop leisure activities, because sometimes these behaviors are exhibited because the child has nothing to do. Use as much as positive language as possible. Maintain your volume. Like you can have positive language, but you still are loud for the child. The child might not listen to you. And teach individual ways of relaxation. Next. Now, parents are the most important people in the child's life, and they are the advocates who can change the child's behavior. So the parents should be on board when the therapist or the pediatrician wants to change an inappropriate behavior and bring about positive changes in the child's behavior. So the parents should be aware about the function of the behavior. The parents should, be on the same page as the therapist or the developmental pediatrician is, and try to do the same things which the therapist or the pediatrician is doing. And they have to reiterate and do the same things at home all over a period of time, and with consistency. The consistency is very, very important if you want to change a child's undesirable behavior. Next. So having a positive parent-child interaction, parents should have special fun time together. There should be liberal praise for the parent, for the positive behaviors. There should be more do's than don'ts. We usually, go on telling child, don't do this, don't do that. We should not be doing that. We should be telling them, okay, you want to do this, we can do this. Okay, try and maintain as much as eye contact as possible. Use simple, clear and direct language. And there should be consistency in teaching. You cannot do one behavioral strategy today and not doing it for the next 15 days. You're not going to get the outcome that you want. Next. So this is how some star charts and all you can give. Now coming to some of the behaviors. Next, sleep problems. We all know sleep is so important. It is a biological must that everyone should have. 40 to 80% of our children have developmental issues. Improper sleep not only affects the, also causes a lot of problems in the daytime functioning and causes adaptive behaviors. Most common sleep problems that are sleep are like bedtime resistance. They have awakenings, and there can be issues such as the excessive daytime sleepiness. Next. So how do we diagnose this? How do we diagnose sleep problem? Just ask the parent to maintain a sleep diary. Is a diary wherein the parent writes what time the child got up, what time the child got up in the morning, this behavior in the morning after getting up. So these are all the things that you should ask the parents to keep, and you should like just go into it and see whether they are, what is wrong in the environment at that time. There are other questionnaires also, like the children's sleep habit questionnaire or the best questionnaire that are freely available on the internet. And most important is the management. If you have a good sleep hygiene, that works wonders for the children who have sleep problems. And a behavioral intervention program. And sometimes if all these fails, then you can have drug treatment as in melatonin. Next. So I just want to show you how a sleep program looks like. So we have to ensure that if the child has to sleep, we have to be tired, right? So we have to adequately exercise through the day. There should be enough exposure to sunlight. There should be limited caffeine intake, as in decreased sugars, decreased coffee, or maybe decreased beverages, soft drinks, because they have a lot of caffeine in them. Limiting naps during the daytime. Even children who like sleep beyond 4 o'clock is not to be encouraged, because then they're not going to sleep later on. Next, then there should be, you should ensure that when you are giving them a behavioral hygiene at the night, there should be dim lights. You cannot have a bright lights and expect the child to sleep. No, that is not going to work. You should do soothing activities and use a proper visual schedule for children, like the one that I have shown, especially in children who have communication difficulties. So if the child sees this visual schedule again and again, the child will understand, Ki, Baba, these are the things that I have to do, and after that I will be able to sleep. And always ensure that sleeping always takes in the bed of the child. You cannot expect the child to sleep in the hall, and then the child will not know what to do. If suppose the child is playing also in the hall and also sleeping in the hall, it might be difficult. So you should have a defined workspace and a defined sleep space for the particular patient, especially children who want everything perfect. Next, behavioral problems are agitation. Agitation are behaviors wherein the individual is restless and hyperactive, and it can manifest like ADHD or ADHD-like symptoms. Children with intellectual disability or children with other special needs, sometimes like ADHD might be difficult to diagnose, but its prevalence is quite high, 9 to 16% versus 5%, which is still seen in the general population. We can use the DSM-5 criteria for ADHD. You can use other scales like Connor's or the behavior assessment scale for children. Next, we have to ensure that whoever is treating it should know what is ADHD first. Okay, it is not only attention deficit hyperactivity disorder, it is basically an executive dysfunctional disorder. So if you know this, you have to focus on the strengths and the positives of the patient. You can change the slide, doctor. You have to ensure that the child is having daily physical activity, having his routines and plans well, and he has set reminders to remind him, Baba, if I'm doing this, then I have to go to the next task. Next. I've already gone through. Okay. Now, if the child fails to respond to the behavioral intervention program, what we can do? Well, we can start and give them drug treatment. Methylphenidate is a stimulant drug, which is most commonly used in children. It not only improves the inattention, it also improves the hyperactivity. However, it worsens side effects, it causes tics and social isolation, especially in children with ID, intellectual disability. Other drugs like clonidine is a wonder drug, especially in children with intellectual.
Dr. Aparna, we cannot hear you.
Low functioning and very high hyperactivity commonly see in children with disabilities. Next. So it can be like exhibited by, hitting others, biting others, kicking others, or it can be exhibited by, destroying certain things like breaking the windows, screaming, shouting, breaking the TV and other behaviors. Sometimes it can be directed towards its own self, like biting, self-eating. Next. So if they explain to the child, okay, Baba, these are the like the anger rules.
Dr. Aparna, we cannot hear you.
Kindly hold on. There are Webley technical issues. We would start in a while. Kindly hold on for a minute. We are working on the technical issue. Dr. Smarnika, can you change the slide? We shall continue with the slides now till Dr. Aparna joins. I'm a pediatric physiotherapist. I would like to tap upon certain things that we need to keep in mind while dealing with children having behaviors. Now, next, what Dr. Aparna would like to mention were the sexual behaviors. Now, sexual behaviors we usually seen in children who are teenagers, and they start self-stimulating themselves in publicly because they are not able to express their needs, and it is very obvious when they attain sexual maturity, they would try to do certain behaviors which are not accepted in the society. So it is very important that parents as well as the people, caregivers or the therapists that are working with the children to note this behavior at the earliest and take them to the psychological counselor so that the psychological counselor further assesses him and then gives appropriate medication and remedial behavioral modification therapies. Then even when the child is growing, he is very much attached to mother or caregiver, and he what he does is whatever behaviors he is showing with the mother, maybe towards in a caring way towards her mother, hugging or doing showing any affection in any way, he tries to show the same behavior with others which may not be socially accepted by others. So it is very important for the parent to understand these behaviors, that it is not right, others will not appreciate these behaviors. So it is very important for the mother to say that it is it is what you show to a mother at particular age, not further on ahead or with others, because even others would try to take advantage of this behavior, and even these children may be sexually abused. Then other things is exposing the body parts. It is of course not acceptable in society. So of course the parents, it is very important role of parent to make the child understand what are the parts which the child should not show or should be comfortable owing only showing to the caregiver and not anybody else, and that do not allow to touch these parts by any other person other than only while taking bath or while self caring, if the child is again dependent on parents. Dr. Smanika, can you change the slide? Okay, these are few salient points that doctor has mentioned. Children with special needs consider asexual
considered asexual, have no feelings, but it is not true, because children, as others, like any other normal human being, even they have sexual feelings which can come up and can be seen as sexual behaviors. Learn intrinsically as a natural part of growing up, also learn from peers. So they tend to see other peers that probably they are showing certain sexual behaviors, or showing affectionate or attraction towards opposite sex. So they tend to learn from their peer groups, especially if the child is a slow learner, or the child is going in a normal, what do we say, it is integrated social community. So the child learns from other people. Of course, we have a lot of media that show these behaviors these days, and the parents have to be very careful in order to in order that the child learns appropriate discipline behavior and does not take any negative sense from social media. So exposure of such social media should be completely limited. While giving the phone also, right now there is online learning going on through phones, through laptops. So it is very necessary that the parents switch on to safer mode while giving the media to their children. Now, sexual content around us, of course, I mentioned this, that advertisement films, they show this sexual attraction towards opposite sex. So children may learn from them, and children who are teenagers, who are having lesser functional abilities, whose IQ is near normal, they tend to learn all this thing from their peers and surroundings very quickly. So we have to be very careful while showing this particular content to them. Then confusing for individuals who cannot ask and share their curiosity or concerns. Yes, of course, I said that special children have communication issues. They cannot tell their own needs sometimes, what feelings they are going through, emotional. And when they attain sexual maturity, it is even more difficult for them to tell that how much they are into how much they are, what all experiences they are having. They may have aggression, they may have certain physical factors which are going on in their body, because of which they experience pain, difficulty behaving in the society, and they may not be able to express it well. So even they happen to go in a shell during this puberty time. So they may even become depressed, because they are experiencing different changes in their own physical appearance, and probably they may go into a depression, or sometimes may even show aggressive behaviors. So it is very important that parents notice these behaviors and bring forward to a developmental pediatrician, and which may in turn refer them to a psychological counselor. Next. So it is very significant. As I said, sexual abuse is very much common in children who are teenagers. So we have to note any changes in the signs, whether the child is over responsive, overwhelming, getting aggressive, or being like into the shell, being depressed, not talking to anybody. So we have to note these signs. Then again, they may have genitourinary tract infections, as there are physical changes occurring, especially in females. There may be vaginal discharges, due to which they may have itching or any other infectious discharges. So parents have to note that as well. Also, like basic sanitary hygiene has to be taught to a girl child. And also males. It is very important that parents of the same gender take care of their children and counsel them that these are the physical behaviors that are seen, and behavior change, physical appearance changes that are happening, and the issues may come up slowly as they grow. It is very important that they take care of personal hygiene. Also, tight fitting clothes may be a difficulty, like the children may struggle.
Dr. Gauri?
Dr. Aparna has joined us now.
Yeah.
Dr. Aparna, you can please carry forward with the slide. I hope you can see it.
Yeah, sure. Yeah, I can. Yeah. So whenever we see a child with sexual abuse, especially a child with inappropriate sexual behaviors, it is most important that we rule out sexual abuse. More so, sexual abuse occurs in these children because they are in, under the care of multiple caretakers. Sometimes the most intimate care has to be done by the other people. Sometimes they could be having genitourinary tract infections like candidiasis. They could be having some rash. They could be having pinworm infestation, especially if the child has not been dewormed. There could be tight fitting clothes. So these are the most important things that we have to deal into. Why more so? Because most of these children sometimes are not toilet trained and they are on they are on using Pampers. So because of which, if the Pampers are also used beyond 4 hours in a child, these children are predisposed for genitourinary tract infections. Sometimes because these children are thought to be asexual, we do not give them privacy to exhibit their masturbatory behavior. And we do not teach them what is private behavior, what is public behavior, because of which the children start exhibiting these behaviors in public places. And then we say that the children are exhibiting inappropriate sexual behaviors. And sometimes there could be some side effects due to which the child is not even aware what he is doing. Next. Okay. So when we do behavioral interventions, we have to ensure that we teach the children about body parts. Teach the children what are private body parts and what are parts which can be shown to the public. So private parts are all parts that are covered with our undergarments. And we have to tell the children and reiterate these statements again and again that these are the things which are not to be touched by other people. Always ensure that we use the appropriate names. Like if suppose there is a penis, we have to call it penis. If it's a vulva, we have to call it vulva. Once it so happened that your young girl told the teacher that her flower has been touched by a particular person, and the teacher could not, comprehend what flower is. But it so happened that a mother had, taught the child to call her vulva flower. And when the sexual abuse happened, the child was unable to tell. So these are the things, we have to ensure that when we are teaching, we use the proper names to teach private parts. Also, we have to show them again and again that private acts are to be done behind closed doors, such as bathing, getting dressed, being unclothed, or even actually digging nose is actually a private behavior. But all these behaviors have to be done behind private doors. And you have to have a own private space. If suppose we don't even have a bedroom, doesn't matter. We can do it like behind a door or behind a curtain wherein nobody can see it. So these are the things that we have to keep teaching the children. Next. So this is just to show you all like which are the things that the children can be shown not to be touched by other people, that are the lips, the chest, in between legs and buttocks. Always talk to your growing children also about what is happening to your body. What are the things that are going to change, how there will be changes in their body, like with the appearance of pubic hair, there will be breast growth that is happening. Discuss about wet dreams, discuss about menstruation well in advance. Don't wait for the menstruation and then talk about it. We have to ensure that these things are every visit, like more so even by the pediatrician treating special educators and the therapists who individualized educational programs for these children. So there is something called as the visual circle. This is a very, very important program that we have to teach. We have to teach the children which are the things that we can allow our parents to do. What are the things that we can show to our parents? What are the things that we can? What are the things we can do with our friends? Things that we have to do with strangers. This thing purpose, as you can see in this diagram, we at the center where private is written, you have to put the child's photograph. In the big hug, you can put the parents or whoever the child is comfortable with. A faraway hug would be like, to your maushi or to your aunt, uncle, like that. A handshake would be with people like, who you see every day, maybe your peers. A wave would be like to neighbors. A stranger, definitely in red. So put any picture of a person who you see and tell the child that when you see or encounter a stranger, you are not supposed to say hello to him, so that this abuse does not happen. Next, coming to the self-injurious behavior. Self-injurious behavior is most commonly seen in children with severe intellectual impairment, as in cases with Lesch-Nyhan syndrome, Cornelia de Lange syndrome, Fragile X syndrome, and Prader-Willi syndrome. They are seen in patients with poor social skills, and they can be also managed by using appropriate behavior management strategies and appropriate communication aids. So now coming to this scenario where Mary was biting her hand and the staff member was giving her a toy to play with so that she stops. But what was Mary learning? If I bite my hand, I get a toy. So Mary, who was having severe communication difficulties, for her biting was a behavior to get the toy. But if Mary was given appropriate communication aid, like a picture of the toy, so that whenever she wants the toy, she shows the picture and she asks for the toy, then this biting behavior can be changed and it can be diverted to an appropriate behavior. Next. So sometimes the self-injury may be strengthened by sensory stimulation. Suppose there is head banging happening, there is eye poking happening, or scratching, which is happening again and again, like scratching. Prader-Willi children report a lot of scratching. Fragile X syndrome patients report a lot of scratching. But then there is a sensory component to it. Here the role of the occupational therapist will come into play. So whenever we see a self-injurious behavior in a patient, it is not necessarily because only of sensory stimulation. It can be because the child wants to communicate also. And sometimes in children with autism, because of impaired opioid release, they tend to do the self-injurious behavior again and again and again, to the extent there is extensive tissue damage. Now, how do we manage it? Manage it by, ruling out organic causes of the pain. See that you have a sensory evaluation done and then appropriately give a good sensory diet. You can use good protective aids such as good materials. You can change the slide, doctor. Or you can use plexiglass. You can, most importantly, try to incorporate an appropriate behavior to replace the inappropriate self-injurious behavior. Next. So this is just roughly to tell you that, to incorporate good practices, we have to ensure that you have a good individualized schedule. You cannot have one program which is like good for all. For every person, you have to ensure that you are making an individualized, tailor-made approach. You have to decrease the unstructured time and keep the child busy in good some activities. Also, you have to provide clear established rules, boundaries, and expectations. Provide visual communication. Give attention so that it is not sought through self-injurious behavior. Striving for consistency among caregivers to reduce confusion and provide a consistent reinforcement schedule. Next. When management fails, definitely you have to resort to the help of drugs. There are no clear-cut drugs which help children with self-injury. Opioid antagonists like naltrexone, atypical antipsychotics have been tried, but try these drugs also, they come with undesirable side effects like risperidone is known to cause metabolic syndrome. You see children who are on risperidone, like, very fat, they have huge appetite, they have sleep problems, but sometimes these drugs do occur in a small patients with severe self-injurious behavior. I really apologize for the severe internet connectivity issues that I had, and please, I hope like I was able to give the message out to you all loud and clear, and I really apologize once again, and I'm open to take the questions now.
Thank you, Dr. Aparna. We have few questions coming up from the audience. I request Dr. Palasha, another member of Indian Association of Physiotherapy Women's Cell Goa, to take over this question and answer session.
Okay.
Hello. Thank you, Dr. Gauri. Now we will start our question answer session. A question comes from the panel. If a child shows uncontrollable behavior like screaming in public, what can be done? What measures can be done by the parent, like an immediate response, to curb or basically to hinder the behavior from creating issues or as such?
Okay. So suppose if a child is exhibiting screaming behavior. So first of all, we have to analyze why the behavior is happening. Sometimes you said that the child is exhibiting this behavior in public places. You know, sometimes some children might get overwhelmed with public when there is too much of crowd. So we have to do a detailed behavior analysis of this patient. You have to see like in which situations the screaming is occurring, how severe is the screaming. So for any behavior that is happening, first thing that you have to do, you have to not give attention to the screaming as much as possible. So do not give attention with your eyes. Do not give attention with your mouth. Okay. Don't even try to cover the mouth. The screaming is definitely going to stop after some time. As soon as the child stops screaming, that is the time you know, catch the child being good and praise the child. Oh, I really appreciate that you are quiet now. Or, you know, something that a child really likes could be given immediately when the child stops screaming, and not at the time when the child is screaming. Suppose the child is screaming to get an object and you are giving the child an object so that the child stops screaming. No, it's not going to work. So the child is only going to learn that next time if I scream more louder, I'll get another toy. Okay, so just try and ignore the behavior for that time and remodel or redirect the behavior to some other thing.
Yes.
I hope I was able to cover the point.
Yes, thank you so much, Dr. Aparna. Another question comes. So when the child is sometimes in such situations, the child is given sedatives and may not be active. So there can be some parents who can use sedatives but how can we stop the medication such as sedatives to make the child less sleepier and basically to wean the medication and achieve better therapy?
Okay. First of all, actually sedatives are not to be used over the counter. Sedatives will be given to the patient only under the prescription of a doctor. And as I said, benzodiazepines are the most commonly used sedatives that are given to patients. It could be like diazepam, it could be like clonazepam, but these also have undesirable side effects and to be used beyond a certain period of time. Suppose having severe sleep behaviors. Actually, according to the guide, no drug which is approved FDA for use for children with sleep problems, behaviors like this, because most of these drugs have antipsychotic side effects, and it is difficult to monitor. You know, the behavior is secondary to the side effect. It is primarily a behavioral problem. So, as much as first thing first is only most important modification therapy. Drugs is everything. Resorts have, you know, gone for a toss. It's just not improving. That time we will give the child medications to treat a particular problem.
Okay. Another question comes from the viewers. Is there any specific diet which is ADHD friendly?
Yeah. So for ADHD patients, like basically ADHD is a disorder in which there is no good release of dopamine that is happening. Dopamine is a hormone which helps our brain to do things in a proper way. Like ADHD is basically due to improper functioning of our prefrontal lobe. The prefrontal lobe of our brain is considered the CEO of our brain, one who tells us to do things in the proper way. Like if I see a child who comes, if I see my teacher come into the class, I immediately stop talking. Why? Because I know if my teacher sees me talking, then she is going to beat me or hit me. So actually, to improve the dopamine, there are drugs like methylphenidate and all. But diet, there is no particular diet as such. But still, we recommend for some of the patients to stop taking lot of caffeine. Why? Because caffeine causes lot of alertness. Okay, and then the child is on active mode, so the child will run a lot. Also, some diets containing lot of food colors or food additives, they also tend to exacerbate sometimes hyperactivity, or a lot of sugar containing products like too much of chocolates and other things which contains a lot of sugars can exaggerate. But there is no specific diet as such. We can try to decrease this in a diet, and we can hope like things can improve. But
Dr. Aparna?
ADHD basically responds.
Yes, yes, you can talk. We were not able to hear you for a second.
Okay,
Now
I can talk
fine.
again.
Dr. Palasha, please carry on.
Yes. Dr. Aparna, mention some scales that can assess ADHD and behavioral pattern.
Okay. The most commonly used scale to assess ADHD is basically the Vanderbilt's scale. And in these scales, we have something called as the parent reporting questionnaire, and we have the teacher reporting questionnaire. There are some questions like, we have to fulfill at least 6 criteria out of the 9 criteria. As we know, ADHD is of 3 types. It is inattentive type, hyperactive impulsive type, or a combined type. So if a particular person or a particular child fulfills 6 out of the 9 criteria in both the parent as well as the teachers or the other caretakers checklist, and if this behavior is causing severe functional impairment, we would say that the child is having ADHD disorder. And then depending whether we can categorize it as inattentive type, hyperactive impulsive type, or combined type. Apart from Vanderbilt scale, there is something called as the Connor's rating scale also, and there is something called as the ADHD index, and there is also the behavioral assessment scale in children, which are usually most commonly used to diagnose children with ADHD. And not to forget the DSM-5 criteria.
Okay. One more question. Can aquatic therapy help ADHD children? Also, what effect can high intensity or low intensity activities such as swimming or gymnastics have on children with behavioral issues?
Okay. Aquatic therapy means I have not actually come across studies as such, relating to role of aquatic therapy in treating the hyperactivity. But as I said in my days, a child should have a good physical routine. The child should exercise, like especially the children who are like high on energy, who have a lot of energy and they don't know what to do. So thus, these children can be diverted to maybe like swimming, or doing some physical activity like running, pushing, pulling. This definitely tends to calm down. Why? Because it causes release of dopamine, and dopamine is the hormone which is deficient in children with ADHD. So when we are doing exercising, what are we doing? We are releasing dopamine hormone, which helps us to think and regulate ourselves. So definitely is going to help.
Okay. One more question comes from the viewers. If the child starts crying and cannot stop, what measures can the parent take to divert the attention or to distract and basically to calm the child down?
See, this is a very broad question, I would say. First of all, the question is like the child starts crying. So again, we will have to do a behavioral analysis only. Whenever see a child crying, we have to see in which environment the crying is happening. What had happened just prior to the incident when the child started crying. So we have to see the antecedent and we have to see the consequence. So sometimes if the child cries to obtain an object, and the child gets the object, that is the consequence is being given to him, the child learns that if I cry, I get the object. So the consequence will have to be changed. Or if the child cries probably on looking at a stranger, then probably the child is suffering from something called as stranger anxiety. Or if the child cries when he is taken into into the new school or a new place and the parents just suddenly leave him there, then probably it is separation anxiety, probably that is happening. So most importantly is that, you tell the child well in advance what is happening to him. Or if suppose we have a child with autism, or for practically any child, if we are going to a new place, new event, we have to ensure that we tell the child, Ki Baba, we are going to a new place now. This is what is going to happen there. These are all the people that we are going to meet there. And this is what you have to do there. So if the child is well prepared and knows what is happening to him, the child will be better behaved and better calm. This is what I have seen with my patients who exhibit crying when they are taken to new places and to meet new people.
Shane Ramos asks, are there which centers in Goa can be directed to the parents for assessment and treatment?
See, I am working at a pediatric neuro rehabilitation center. We see a lot of patients with behavioral difficulties here, right from 0 to 15 years of age group. So we are open all the time. Apart from this, the place where I have done my fellowship from, that is Setu Center, is an excellent center where multidisciplinary treatment and assessments are provided. And of course, the district early intervention centers, both in Asilo as well as Hospicio, you all can refer the patients there as well.
Shika Arya asks, a child diagnosed with cerebral palsy with few traits of autism does a lot of self-talk. The self-talk is usually consists of instructions in mother tongue that the parent gives throughout the day. They sleep less, just about 3 hours at night, and continues self-talking, which hampers the attention a lot. And the child can talk and follow the instruction anyways. So what can be done in this case?
First of all, a child with cerebral palsy with autism, I have had cases. It is quite a common combination because autism can happen to all. But whether the child's also sleep problems in children with autism is a common condition. We have to, so you said the child has cerebral palsy. First of all, we have to see why the child is not sleeping first. Whether there are any organic causes to the child not sleeping. Maybe the child, because of his cerebral palsy status, maybe is having a dislocation, or whether the child is having severe spasms of the leg. Maybe the child is not getting to relax his legs. Maybe the child requires an anti-spasticity medication to decrease the pain associated secondary to the spasms. If that is, you mentioned that there is no dislocation. But if that is all ruled out, okay, what you can do is that start by first giving a good behavioral hygiene, a good sleep hygiene. As I said, okay, spasticity is not much also you said. So start by giving a good hygiene. First of all, you, as I said already, you should have a consistent bedtime and a consistent wake up time, no matter what. Okay, you try to take the child to the bed on time as possible. Okay, then try to associate the child sleeping with a kind of a sleeping toy. Sometimes, parents keep the child on the bed and they tend to go outside. Some of the children want that security around them. My parent is there. My parent is going to put me to sleep. So wait till the child falls asleep and try to work around the scheduling of the sleep behavior of the child. If the child is getting up or waking up in between, do not put on the light immediately. Why so? Because melatonin is the main hormone which helps us to sleep. And if the melatonin secretion is impaired, then which mostly happens because of bright light, the child is not going to get to sleep. So yeah, but see, we have to be consistent in our approach to treating children with sleep problems. You cannot do the intervention one day and expect, second day the child to sleep. You have to be consistent. Why more so I am telling this? Because I had done my study on sleep problems in children with autism. And what I found is that, if the sleep hygiene measures are followed routinely again and again, probably, the children's measures sleep can improve. So consistency in sleeping patterns, consistency in wake up time, you have to ensure that the sleep area is always the same, ensure that there is a calm, cool environment, ensure that there is no noise, and most importantly, no TV at least 3 hours prior to the child's sleeping time. This is something that has to be practiced day in and day out. Also, because most of the times, because children don't sleep, parents tend to put on the light, put on the TV, put on the mobile. Sometimes even the TVs are in the room. All these measures should be completely stopped. No screen time is to be given to the children at least 3 hours before sleeping. And we should follow the American Academy of Pediatric guidelines, which state that children less than 18 months, you have to give 0 screen time. Between 18 months to 8 years, you have to give just 1 hour of screen time. And more than 8 years, it's just 2 hours, that too under parental supervision. I am sure, like, if these measures are followed, definitely we can ensure that the child will sleep to some extent. But in spite of these consistent measures, the child is still not sleeping, then probably the child will require a drug trial, mainly melatonin, which is given in the dose of 0.05 mg per kg, at least 1 to 2 hours before bedtime. Once the child achieves good sleep pattern, then we can taper it and omit it.
Thank you, Doctor. Meghna Gandhi asks, biting clothes and moving continuously in case of ADHD child, is it a behavioral issue? And if so, how can it be reduced? Will medication help? And does the child need behavioral evaluation and modification therapy?
Yeah, it's a very good question. Now we have already said the child is having ADHD and the child is pacing a lot in the room and the child is biting its clothes. So that pacing, we should see whether it is causing any functional impairment. If suppose the child is exhibiting this behavior at home when the child has nothing to do, or biting the clothes when the child is anxious and it is not at all times, I don't think we have to treat it. But if this biting of the clothes and the biting and the pacing is interfering his classroom pattern, then definitely it has to be treated. Then probably if behavioral, like if you give the child an activity which the child really likes to do and is interested to do, it should be as much as child-centered as possible, not therapy-centered or not parent-centered. It should be an activity that the child likes. Okay, try to decrease the anxiety by making the child relax. And if these measures don't work, methylphenidate is a beautiful drug that helps to treat the hyperactivity and the pacing in children with ADHD.
Last question. Deepti Shastri asks, how do we control aggressive and destructive behavior in children? If a child is aimlessly running in an open area and does not stay in a place, gets easily distracted in about 5 to 10 seconds during an activity and keeps jumping, is the child in ADHD spectrum? Also, if a child does inappropriate and uncontrolled behavior in public with a stranger, what measures can be taken to control?
Okay, that's a very good question. So the child is exhibiting destructive behavior in public, and the child is getting easily, diverted from the task that is given.
Dr. Aparna, I guess there is some issue with the connectivity.
So give the child a task that the child is interested in. Don't give him a task that the child is not interested in. And even if the child, is given a task that he is interested and then blanks out or cannot focus, okay, then probably, his attention span was only that much for that time. So whenever the child looks in, give him positive reinforcement, like a social tangible, or you can give a positive reinforcement strategy, that can make the child focus on the task and do it. Even if the child let him go. After some time, when he comes back and does it, make sure that you work on the consistently on the his time stretching, so that he can do it for more periods of time. And coming to the child mixing up with a lot of strangers, I guess So again, that circles program that I had shown you all, the child should be taught again and again that strangers are people with whom one should not get mixed. Okay, because of chances of abuse, and so that the child knows. So this has shown to the children every day, and this has to be much as visual as possible. You show the pictures of the people who are there in his environment, like the parents are very close to him. His teachers, caretakers will come in a circle. His doctors and neighbors will form that. So strangers are a strict no. So if the child is understand verbally, well and good. If the child is not able to understand the verbal thing, then make it as much as visual as possible.
Thank you, Dr. Aparna. Yes, thank you, Dr. Palasha as well. I think most of our queries, doubts have been addressed by Doctor. And since this is a very vast topic, we would have very specific questions related to our own children. So I think you can approach us later on. You can all put up your questions on YouTube link that has been shared already in the chat. Our panelists would again share the link with you all. So we can address it later on. Also, Dr. Aparna is practicing in PNRC Center, Pediatric Neuro Rehabilitation Center, Goa. So you can consult her on appointment basis whenever it is possible for you. So thank you so much, Dr. Aparna, for enlightening us and providing a very valuable information. So as we conclude now, I request Dr. Parul to give vote of thanks.
Thank you, Dr. Gauri. Am I audible?
Yes, you
Hello.
are.
Yeah. Okay. Thank you, Dr. Gauri. Good afternoon, everyone. I'm delighted to get this opportunity to present vote of thanks for today's webinar. Let me express my sincere gratitude to today's speaker, Dr. Aparna Wadkar, for sharing her expertise with us and enlightening us with her knowledge. It gave us deep insights into the topic and also revealed some interesting facts. I'm pretty sure the precious knowledge that Dr. Aparna gave us will definitely help us in dealing with behavioral issues in children with special needs. Thank you, Dr. Aparna. I'm deeply grateful to Dr. Gauri for handling the presentation well in midway due to some unforeseen errors. I hereby acknowledge IAP Central Committee for providing us this platform and their technical team for the wonderful, consistent tech support. I offer my sincere thanks to IAP Women's Cell Goa team members for working tirelessly in conducting all webinars on a youth scale. I also thank all the attendees for actively participating with patience in this informative webinar. Thank you, everyone. Have a nice day.
Thank you, Doctor. Thank you, everyone, for attending in spite of having technical glitches. We would like to take your queries later also on YouTube. Thank you all for giving your time.